let me see. Hello in the back of the room. Shirley, do you have a mic on?
I don't know. Is this on? We're getting ready to start again, so if everyone could take their seats and put their listening ears on. Thank you.
Your inside voices, is that right? All right, so now we've covered what's going on out there across the country and in various states as people are starting to think about making these changes. And now we want to focus more on this question of specifically mental health and substance use services and integration with primary care. So our hypothesis here is that medical homes and accountable care organizations are going to quickly learn that people who have medical conditions, multiple medical conditions, and individuals with serious mental health and substance use disorders are two populations that are critical to getting a handle on U.S. healthcare expenditures. And so the second part of the hypothesis is that to bend the curve and lower total health care expenditures, we're going to have to spend more money on effective mental health and substance use services in exactly the same way that we're going to spend more money on primary care in order to make the difference in terms of both health status and total cost. And so I'm going to show you some data to help you think about why we have that hypothesis. Let's start with this. This is a new report that came out last fall. It looks nationally at claims data for all people who are on Medicaid due to disabilities. And what they found in this new report, this is the Faces of Medicaid 3, which means that there was a 1 and a 2, and this is report 3. 49% of people who are on Medicaid due to disability have a psychiatric illness. And that was new information last October because in the previous two reports that percentage had been 29%. And what they did was added pharmacy claims in the analysis this year when they were doing that report, and oops, 49% have a psychiatric comorbidity. And just for the footnote on that, if you're looking at people with disabilities who are dual eligibles also on Medicare, that percentage rises to 52%, according to this report. Now, substance use conditions don't show up in this report in very much frequency, but that's because it's a claims-based analysis. And in many, 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 many places around this country, you get very little if any, services under Medicaid for substance abuse treatment. So it's not in the claims database. Excuse me. The other thing that they found is they looked at the population who were the most expensive of the population and looked at comorbidities. And so you'll see here in this chart that of the top 5 most expensive comorbidity pairs, 3 of them have psychiatry as one of the comorbidities. So it's data like that that has got folks in health policy circles saying, wow, maybe we need to rethink the way we've been thinking about mental health services. And we would add, and I'll show you some more data, about substance use services. There also has been, while all of the rest of this conversation has been going on that I've described to you, ongoing research on integrated care and what is known to work and is shown to be most effective in terms of integrated care, with the largest overview report coming out of the Agency for Healthcare Research and Quality last year, which was a look at 33 separate trials of integrating, in this case, principally mental health specialists into primary care. And what they found in that research is that it is a little hard to tease apart what are, if you will, the key dosage is. What are the key elements in the dosage of those elements? But what they did find is that impact has had the strongest results for adults and older adults. They also found limited studies existing for kids. There's been less work done on this for kids than there has been for adults. And so when we talk about integrated care, one of the things that happens is people fall to fighting among themselves about how to define it. And I like this definition from the Hogg Foundation, which ran a major integration project in the FQHCs in Texas over the last several years. And what they said is, the idea is that physical and behavioral health problems often occur at the same time. Integrating services to treat both will yield the best results and be the most acceptable and effective approach for those being served. The question is not whether to integrate, but how. Neither primary care nor behavioral health providers are trained to address both issues, which is absolutely true. That is kind of the state of where we are, although there's lots of pockets of activity going on around the country. So now we come to the person-centered healthcare home. Because you may have been wondering all the time I was talking about the patient-centered medical home, why I was using that language rather than person-centered healthcare home. And it's because I was trying to describe to you the conversation that's been going on in the rest of the country. But when we looked at that conversation now well over a year ago, we said, there's not a clear articulation of mental health substance use services and its role in the patient-centered medical home. We think there needs to be a role like that. And we're going to start using the term person-centered healthcare home as a way of signaling that these services are a central part of healthcare and that healthcare should include a focus on delivering these services and on supporting individuals' goals for improved self-management. We also said that that means we need to take what we've called a bidirectional approach, which is that we need to address the integration of primary care services into mental health and substance use settings, as well as bringing mental health and substance use services into primary care settings. So it's not a single model. You're going in both directions. And key to doing that in both settings is having a care manager and consulting prescriber functions that have been shown to be effective in the impact model, and use that as an overall construct for implementing bidirectional care. So you see the patient-centered medical home principles on this side and the additional ideas we had about, well, what would make this a person-centered healthcare home? One of the things that the National Council has been thinking about regarding integration for 8 years now is this question of where should care be delivered. And we've focused our thinking in terms of doing population-based work, and that's really the genesis of the 4-quadrant model. Which deals with the fact that there's always going to be a trade-off between primary care and specialty care about the benefits, what's the boundaries. And those things, for those of you who work mostly in healthcare, you know that that's true in general healthcare as well. During the time that I was an administrator at Group Health, we would deal with questions about, okay, when do things move from the primary care clinic to the specialist? What are the protocols? What are the criteria for when that movement occurs? Which is not gatekeeping as much as it is trying to have everybody working at the top of their capacity of what they can manage. So stepped care is the clinical approach to changing the level of care to make it appropriate for each person. And that's really key to the impact model. That's a great deal of what is in the impact model that we'll talk about shortly. And I've already told you that we think we need to implement this bidirectionally. So that brings us to the 4-quadrant model. And tiny, tiny print here, but don't worry, we're going to go into it in more detail elsewhere. I just want you to get the general construct. The idea here is that in any population, any town, you have people who have a range of physical health risk and complexity, which is the horizontal axis. from low to moderate to high. And you have people who have a range of mental health and or substance use risk and complexity from low to moderate to high. And if you think about any population, then you're going to essentially have 4 different subpopulations. And the point of the 4-quadrant model is really to do population-based planning, to say what we need to do for people who are in the population that is in quadrant 1, low to moderate health, low to moderate mental health and substance use. What we need to plan to do, what the work is, who does it, how it gets done, is going to be very different than what we do for individuals who are moderate to high on both axes. And we need to not try to create one model that fits everybody there, because then we won't serve anyone really very well. So if you think about quadrant 1, what that says to you is really everything that we do should probably happen in primary care. We're talking about low to moderate needs on both axes. It should happen in primary care. Quadrant 3, you're still low to moderate in mental health and substance use issues, but you now are moderate to high on healthcare issues, which means we've moved into the realm of specialty providers, specialty medical surgical providers, as well as primary care providers. And so you start thinking of examples there like high-risk OB, pain clinics, cardiac rehab, places where we should have a mental health and substance use component as well for the patients that are being served there. So let's look first at quadrants 1 and 3 and think about those arenas. And let's start by trying to think about how many people, what proportion of the population. And so we know that in the general population, 26% of the population will have had symptoms sufficient for diagnosing a mental disorder in the past year. So in the general population, 26%. We also know that from this study that these disorders actually get started earlier than we have been attending to them, with a strong foothold in youth, with 50% of all cases starting by age 14 and 75% by age 24. So that tells us something about what we should be thinking about when we think about children's services and how we organize for children's services. What's interesting about this study is that if it's 26% of the adult population that needs mental health services in any given year, only 41% of the population in this study actually received treatment. So we have 59% of the people who needed something did not get something. And of those, 80% had been to a primary care physician within that previous year. So we have a missed opportunity in primary care to have identified and engaged an individual with mental health services. What's also interesting to note is that of the 41% who did get care, only half of them received it in the specialty system. The other half received their services in the general healthcare system. So this is where we begin to say to ourselves, oh, the mental health system is really a lot bigger than the specialty providers. There's a mental health system of some kind, ill-formed, not well-shaped, not consistent, but going on out there in the general healthcare sector. And what should we be doing to make sure that that's a more effective system? So we know that primary care physicians are doing a good job of diagnosing and beginning treatment for depression. Most of the SSRIs that are written in this country are written in primary care settings. What we also see, this study being a good example of it, is that they may do a good job of getting somebody started on meds, but the follow-on care leaves something to be desired, either in terms of people completing a minimum course of medications or psychotherapy. A second piece of it is getting adequate changes to meds if you don't respond to the first dosage or type of med that gets written for you. And what's most troubling is that the lowest quality of care was among those with the most serious symptoms, including those with evidence of suicide or substance use. So this is where, and there are other studies like this, where we get the impetus to say we have to do a more planful, thoughtful job of describing what should be going on in relationship to mental health services in primary care settings. A subset of this question of depression is bipolar disorder in primary care settings. And this is an interesting piece of analysis that shows us that of the patients treated for depression in a family medicine clinic, when they were subsequently assessed for bipolar disorder, it was 27% of that population of depressed patients. And so there's another quality issue in terms of quality of care, because whipping out a prescription pad and writing an SSRI for somebody who has bipolar disorder may really send them in the wrong direction. And so being thoughtful about all of the possible things to consider is one of the things that we've been trying to work on in primary care settings. So for the National Council, I've run the collaborative that we've had going now for 3 years. We've had 16 sites across the country, and every site is a mental health center and an FQHC paired. So they're partners, and the intent is to improve the quality of mental health care in primary care and to improve the quality of health care on the mental health side. And what we've asked them to do, all of these sites had to already be doing depression screening in primary care as a baseline to come into the project. What we've asked them to do is add to their screening bipolar disorder screening, substance use screening, anxiety screening, in order to get to a finer level of understanding what it is that is happening in their patient population, and then putting in place both internal protocols and very tight referral protocols to the mental health center. Now, an interesting story about this in one of our site in Indiana, in this last group, very shortly into their year in the collaborative, as they were tracking all of their screenings, they found that of the 600 patients that they had who were depressed, 100 of them had bipolar disorder. And so their first thought was, okay, we've got to get those folks to the mental health center. Well, those folks didn't want to go to the mental health center. And that became the focus of their project, because they hadn't considered that possibility, that if they could get people in and they had a very rapid intake process, it was possible for the behavioral health consultant working in the primary care clinic to actually get on her computer and get an appointment, a right-away appointment over in the mental health center for a referral. But most of the patients did not want to go to the mental health center. So instead what they did was they built a protocol and trained the primary care docs in the medication management for bipolar disorder, and the behavioral health clinicians that they had on site in primary care became the backup folks to help do some other kinds of work with those individuals. At the end of the year of their project, when they looked back on the 100 people, 25 had gone to the mental health center, 25 had been lost to follow-up, but 50 patients were stable and being cared for in the primary care setting. Now, those are 50 patients who otherwise would not have been getting services, and they may have gotten much worse and eventually wound up in the criminal justice system, ERs, hospitals, and then maybe back in the mental health system. But that's an example of how this begins to shift the way you think about what's the system. The medical director of the mental health center in this site said at the end of the project, "This process has made me completely rethink the way I think about what the mental health system is and what the role of our mental health center is in it." So that gives you a feel for how, as you begin to dive into doing this work, why it begins to change things from business as usual. So I've mentioned the Impact Project. How many of you are familiar with the GAU project that's been going on in King and Pierce counties for the last couple of years? A few of you? Okay. So this is the model that has been in use in King and Pierce counties and is now being spread to other parts of the state. And there are a couple of key things about the impact model. Originally, research trial was for older adults who were depressed. But here's the important thing for you to know, and that is it's now being used for people who are depressed, have bipolar disorder, have anxiety, PTSD, have substance use disorders, and who are all ages down to and including adolescents, because there's an adolescent impact project, research project going on now. The process is systematic diagnosis and outcome tracking. In the case of depression, it's using the PHQ to track over time an individual's status, and then stepped care in order to change treatment according to an evidence-based algorithm if the patient is not improving. And the way in which that gets operationalized is you have the care manager, behavioral health consultant, who is embedded in the primary care practice and who does the work of patient education, help building self-management goals, coaching for self-management, close follow-up to be sure the patient doesn't fall through the cracks, tracking very carefully how people are doing with their meds, if they're having side effects, and essentially being the person who is tracking the status of that individual, providing brief interventions, brief cognitive interventions, and as patients improve, helping put together a relapse prevention plan, and if they're not improving, help facilitate the transition to step care, perhaps to the formal mental health system. The consulting mental health expert, the prescriber, doesn't see the patients. The prescriber consults to the care manager and to the primary care doc and helps them think about the patients who aren't getting better, so that everybody is focused in looking at this and making decisions about changing care on a regular basis. So if you're working inside of a fidelity impact model, you are looking at how an individual is doing somewhere between 6 and 8 weeks. And if you're not seeing improvement, then it's time for a change. And what you will see in the projects that are underway in the country right now is that 12 weeks, projects that are running very high fidelity models have 50% of their patients with significant remission at 12 weeks. But that's because they're on it in a very focused kind of way. So let me show you some data. This is from the original impact trials. There were 8 sites around the country. The gold bar is the impact model. The white bar is usual care. And what you can see here is that in every single site with very different kinds of populations, types of facilities, payer mixes, the impact model got significantly greater improvement in depression at 12 months. The bars that have the black circle around them happen to be a Kaiser Northern California site where they had a behavioral health clinician in the primary care setting, but not necessarily operating in any very structured kind of way. And so that's usual care. A behavioral health consultant in primary care, but the usual care is not much better than some of the other sites. One of the takeaways from this is you just can't toss a social worker into a primary care setting and say, go forth and do good work, because you are not going to have people who know how to do the work in primary care. It is a different kind of model. Total health care costs. This is reduction in total health care costs. One of the interesting things about this finding is that they got, if you see the white bar, that's the impact in a post-study several years after. After the intervention had stopped, they'd done the project, but people were still getting better. And so in the GAU project, this is the patient mix that we were looking at as the King and Pierce County project started. And it it's an important picture because it keeps reminding us that what we have to be prepared to respond to is people who have this overlay of chronic medical conditions, alcohol and drug problems, and mental illness, and that it is all of these pieces that we have to be able to weave together to serve people well. And this is the model that's been in place in King and Pierce. So this was done across all 6 of the FQHC systems in both of those counties, and there were 10 mental health agencies that participated, the Safety Net Health Plan, the RSN, UW, folks from this department have been on the steering committee representing mental health, alcohol and substance abuse, DVR, CSOs, so that we were trying to bring all the pieces together. You see that this is primary care-based work with the care coordinator or behavioral health consultant being the one who is doing the screenings, working with the consulting psychiatrist, working with other clinic-based mental health providers, and providing what's called level 1 care. So level 1 care being care that happens in the primary care setting. Now, what's interesting about the GAU project is that then there was level 2 care, which is we step people up to the mental health system or to the substance use treatment system. And that's broken out to be about 1/3 of patients go on up, and about 2/3 have gotten the bulk of their care in the primary care setting. The other thing that means is that the entrance into the mental health center isn't like you go and walk in the door. It's your entrance is through primary care and into the mental health center, and there's continued communication back and forth between the primary care site and the mental health center, because you know what? The patient's still getting their health care in the primary care clinic. So at the end of the first year, we took a look at how we were doing on the project. And there, by the way, there's a formal evaluation going on now, but this was end of first year look-see. And we had a couple of key things that we were looking at. Remember, I talked about fidelity to the impact model. So 2 things that we were looking at is how many individuals had a follow-up within 4 weeks of initially being identified as being depressed and needing care. And that number was 42% across all those sites, and you can see here that the range across the clinic sites was from 32% to 64%, which is a bit of variation. Right? This is variation, right? And having a site consult with the case manager, the care manager, 31%, and the variation here was from 20% to 83%. Variation. And then we looked at how many had improved at least 50% at 12 weeks. And both on the PHQ-9 and on the GAD-7, which is the tool being used for anxiety, improvement was only 20%. And we looked at those numbers and we said, ooh, legislature's funding this project, this does not look like the kind of numbers we want to go out there with. So there was a focused quality improvement initiative that went on that took a subset of the clinics and really focused on workflow. What's the roles, what's the responsibilities, who does what when, and really getting that clearly articulated. And when we went back to look at the end of their quality improvement project, you can see that 4-week follow-up had gone up to 93%. They were using both in-person and telephone contacts to do that. And one of the things that we found in these projects is you can use a mix of in-person and telephone. Site consults were at 60%. And the substantial clinical improvement had gone up to between 63 and 72% across the 4 clinics that were involved. So the moral of this story is workflow, being clear about the work is, what the work is, who's going to do it, and then following through and tracking where you are with patients. The biggest barrier that we had to deal with is changing practice in the field. We took away most of the other barriers. As I do integration work across the country, people say, oh, well, the reason this is impossible is because we aren't getting paid for it, and we've got all these regs we've got to follow, and we've got these barriers to sharing information, and if we could only take care of those things, we would be, gangbusters. We would be great. But in this project, in fact, we took away all those barriers because they did get paid for doing the project. We in King County said, we're not even going to use the access to care standards. If the primary care doc, behavioral health clinician, and psychiatric consultant agree this person needs to step up to the specialty mental health system, they go. Took that barrier away. They were all using a single electronic registry where both primary care and specialty entered information into a single electronic registry. So we took a bunch of things off the table that get in the way of delivering good integrated care, but in the end, we still have to change practice. And that was the biggest thing to be worked through. Now, what has happened since then is that the numbers across all of the clinics have gone up because that was a big learning experience, and that information from the Quality Improvement Project was shared with the other sites, and so we're looking at much better percentages. But it was a first year that was very informative for everybody in the project. Now I want to focus specifically on substance use conditions because most of the integration work that's gone on to date has been focused on mental health issues. And yet, what we saw in the GAU project is that overlay of substance use issues that I showed you in that overlapping circle slide, that Venn diagram. So this last year, the National Council decided that they wanted to focus specifically on this, and you have in your packet the executive summary, actually, of the two National Council papers. The first one is the one that I wrote a year ago on behavioral health integration and the person-centered healthcare home. There's a second paper that just came out in March that's substance use conditions in the healthcare home. You've got the executive summary and you've got the link to the full paper. Substance use conditions are extraordinarily relevant for primary care. We know less about what the numbers are. I could show you the numbers for mental health. What McClellan says when he talks about this triangle and that place down here in the third tier, which is, okay, we've got 23 million people that we believe have abuse or dependence issues, and of that group, only 2.3 million are in treatment. So we're only getting to a very small proportion of people with abuse or dependence issues. And then we have the issue of unhealthy use, and how many people is that anyway? McClellan says it's tens of millions of people across the country. Willenbring says he thinks it's about 21% of the primary care population. What we know is that it adds to overall health care costs, especially for Medicaid. There's data that shows that it's more significant in the Medicaid population. That substance use conditions can cause or exacerbate other chronic health conditions, and that interventions can reduce health care utilization and cost. And actually, Washington State is one of the places that has led the way in researching this, and I'll recap some of that data for you in a minute. But first I want to show you some data from Kaiser Northern California. There's this remarkable thing that's happening in Kaiser Northern California, which is in their research unit, there is a team of people who are very interested in the question of substance use and its intersection with health care. And so they've done a lot of looking at this, and they've got this fabulous database, which is the electronic health record of the Kaiser system that they can use to do this analysis. So in this very first piece that we're looking at here, they looked at the average medical cost per member per month in the 18 months pre and post substance use treatment. And they found that the treatment group had a 26% reduction in cost, dropping $200 a month PMPM, and reduced ER and hospitalizations were the principal reason for that drop in costs. They also have been looking at continuing care, and for those of you who work in the substance use field, you know that there's this emerging conversation that's going on about the fact that we should be using a continuing care model. McClellan has written extensively about the need to use a continuing care model and not say, you had your 28 days of residential treatment, go to AA, we're done. The continuing care model that Kaiser is using is an interesting one. It's substance use treatment when needed, access whenever you need it. It's your primary care provider is checking in with you about this at least once a year. You may be seeing that person for other things. But another thing that they found when they looked at their data is that it included psychiatric services when needed. And that was for any adults that had psychiatric symptoms after they had received substance use treatment. And they found that if people had at least 2 hours a year of psychiatric services, they were twice as likely to be abstinent at 5 years post-treatment. So that little piece more of psychiatric assistance for people who have psychiatric symptoms as well was making a difference. And take a look at what that investment produced. Those with high psychiatric severity at the initiation of treatment had $1,000 PMPM costs, and that was reduced to $300 PMPM after 5 years. So significant, $300 per member per month, or $700 savings when you multiply that times several 100,000 people is a fairly good sized number. And so Kaiser was kind of interested in this number. They found that patients who are receiving this continuing care package are twice as likely to be remitted at every follow-up over 9 years when they check in with them, and that these same individuals were less likely to have ER visits and hospitalizations even if they had periods where they were not in remission. They had still begun to change their patterns of using care. So the kinds of services that we're talking about here in terms of primary care are very different than the kind of substance use services that the public system has developed, because it has developed its services for partnership with the criminal justice system. And this is not to say that that criminal justice system partnership is going to go away, but it also means that we just can't transplant those services, take them into primary care and say, whoa, have we got a deal for you? There has to be new ways of delivering care. And the emerging practices around this are diffusion of screening and brief intervention. There's been expert projects going on here in Washington State for a number of years. And there's a major new investment coming through as a part of the National Drug Control Strategy to build screening and brief intervention capacity in federally qualified health centers. So that's a big thrust of getting screening and a brief intervention into primary care everywhere possible. Related to that is the finding that screening and brief intervention, as it was originally developed, happened parallel to motivational interviewing and was not necessarily using motivational interviewing. And so one of the findings is that you should be using motivational interviewing as your consistent component of your SBI intervention. But then there's some emerging findings that say that repeated brief intervention is a promising practice. And repeated brief intervention means that you identify someone, for example, as having an alcohol use issue. They're not willing to engage with you or anybody else on that issue. The idea is that if you, on multiple occasions over time, have a conversation about the impact of that alcohol on health status. You use health status as the leverage. That eventually what you will see is harm reduction, and you will see people being willing to step into treatment models. So there's a randomized controlled trial that's starting in the VA system to see if we can show that this really is going to prove to be more than just a promising practice. And then the other thing that is not widely in use at all in primary care are medication therapies, both naltrexone for alcohol abuse, buprenorphine for opioid abuse. That can and should be expanded in primary care settings. One of the reasons it hasn't been is, just as was true with depression in primary care docs are really pretty skittish about screening for something if they don't know what they're going to do and the answer is yes. Yeah, don't like to be in that position. Better not to know. Just won't know about that. The next thing is that they're skittish about, okay, now I know and there's something I can do, but I have 3 other people lined up in exam rooms over here waiting to be seen. And so the idea here is that we can probably expand the use of medication-assisted therapies in primary care settings if we go back to what we've learned about the impact model, which is you've got somebody on site who takes the handoff from the doc, so that the doc sets up the transition, but then somebody else begins to work with that individual. And if you have a prescribing consultant who helps primary care docs, even after they've been certified for buprenorphine, to get comfortable with using it and knowing how to do it. So there's an opportunity to apply the impact model in doing some of this work, substance use work, in primary care. So what kind of skills do people need to do this work in primary care? I think what we've found thus far is they can be any licensed practitioner, that training, orientation, and skills are the key. I mean, you'll hear people say psychologists, social workers, and then there's some issues around MFTs because FQHCs can't reimburse for MFTs, but it can be any licensed practitioner. They need to have very good clinical assessment skills, and I would argue that they have to be competent in both mental health and substance use assessment and intervention. Very few primary care practices are going to be able to afford and organize having 2 different people and saying, okay, now let me see, is this the mental health person or the substance use person? And you're not very helpful to a primary care doc if you mainly do mental health and you say, I don't do substance use, so I can't help you on that one. We need to train a workforce who is competent in both to work in primary care, because that's going to fit that team-based model the best. They need to have cognitive behavioral intervention skills, group skills, consultation skills, communication skills, psychopharmacology, and behavioral medicine. And by behavioral medicine, what I mean is a whole other piece of behavioral health work in primary care, which is thinking about helping people learn how to manage their diabetes, how to change their self-management structures for diabetes. Flexible, independent, and action urgency-oriented, solution rather than process-oriented, and wait, there's more. Prevention orientation, team-oriented, clinical protocols-oriented, focus on impacting functioning, not personality, experience with the SMI population and the public mental health and substance use system, understanding the impact of stigma, organizational and computer competency, and be bilingual and culturally competent to serve the major population groups. And this list was put together, we put this list together, I think it was 5 years ago now. Dennis Freeman at Cherokee Health Systems, which is one of the major examples of integrated care in the country. It's in East Tennessee. And Susan Wilson, who at that time was at Swope Health Services, a major FQHC system in Kansas City, and myself. So we kind of compared notes about what we'd been learning and created this list. And as a practical matter, that is what people have to, have some pieces of in order to be successful in a primary care setting. So to recap the person-centered healthcare home for quadrants 1 and 3, we need to incorporate the lessons of the impact model, explicitly build in care manager, behavioral health consultant, care manager, and consulting prescribers. And again, all health care is local. So working out the details of who does what for who has to engage local partnerships to do this. And there's been a piece of work that I've done around building partnerships in California that we'll be taking a look at in part 2 of this series. So the things that are in that tiny print in the first 4-quadrant box these are the elements that you would look for in quadrant 1 and in quadrant 3 for the person-centered healthcare home. I'm not going to read them to you, but this is the recap of what should be there. And now I'm going to stop and take questions on quadrants 1 and 3. just a few questions so I can move on to quadrants 2 and 4. Any questions? Clear as mud? Okay.
Annette Barnes, I'm the family liaison with the Division of Behavioral Health and Recovery. I'm a consumer of our services as provided, and as I look at this, I think it's a fine model. One of the questions I do have, though, is the practice of utilizing peers such as myself in the recovery process, whether it's through the medical intervention or mental health and substance abuse. And just want to know, where does that fit into this?
You know, there are some interesting projects that are underway around the country on this now. I think there is an opportunity for peers to work in primary care settings. There's even more opportunities when we get to talking about quadrants 2 and 4. But there are, in a couple of projects around the country, certified peers are getting additional training to become health coaches and to be able to apply their knowledge not only about living with mental health and or substance use disorders, but also then helping coach people around those issues and diabetes, or those issues and cardiovascular disease. So that's one of the things that I see emerging as we speak.
Okay, I have one other question as well. As these plans were brought forward, part of that oversight team or whoever's bringing that together, are there patients or consumers such as myself that sit in those to help design?
In the projects that I'm mentioning?
Not necessarily so much in the projects, but in the overarching, from the federal level, as to how these steps were put into place. I mean, is there the voice of the people who actually receive these services? For the medical home initiatives, yes, but they are patients from the healthcare perspective, because again, we're just bringing this mental health substance use stuff into quadrants 1 and 3 for people to start thinking about. But there has been patient perspective on the development of the medical home model. Yeah. Thank you.
Other questions?